Good evening. This is Dr. Prakash Khetan, Senior Consultant Nephrologist, Kingsway Hospital, Nagpur. I was formerly Managing Director of Kingsway Hospital. I have been practicing in the Nagpur for last 25 years, and my interest is into chronic kidney disease, dialysis, and kidney transplantation. Chronic kidney disease is an unresolved enigma, and it is defined as a condition wherein the kidney suffers irreversible damage over a period of months to years. And to make you know about chronic kidney disease is very common, and the prevalence is ever increasing in last 3 decades. And once the chronic kidney disease develops, it is progressive and irreversible, and either ends in a premature cardiovascular death or reaches end-stage kidney failure, wherein the patient requires renal replacement therapy in the form of either dialysis or kidney transplantation. We all have two kidneys which are located on either side of the vertebral column in the upper part of the abdomen, and the main function of kidney is to remove the waste products which are generated out of our metabolic processes and excrete these metabolic waste products into the urine. Normally, the kidney filters around 180 liters of blood throughout the day, and out of these 180 liters, almost 99% of the blood is returned back into the circulation. Only about 2 liters of urine is found out of this 180 liters of blood that gets circulated to the kidney during 24 hours time. So, socially underprivileged people are more at risk of developing chronic kidney disease, and the CKD or the chronic kidney disease undergoes various stages, and it can be divided into 5 stages which are based on the estimated glomerular filtration rate and the albuminuria. Stage 1 chronic kidney disease, when here the GFR is more than 90 ml per minute per 1.73 meters square, and but the patient has structural disease in the form of either abnormal sonography or proteinuria or some other structural damage to the kidney, wherein the kidneys are at risk of developing further progression. Stage 2 is when the eGFR is 89 to 60 ml per minute. Here also there is proteinuria. There may be proteinuria or associated histopathological changes proven on biopsy or structural diseases proven on the sonography. Stage 3 is divided into stage 3A and stage 3B, wherein the eGFR is between 59 to 45 ml in stage 3A, and stage 3B the eGFR is 44 to 30 ml per minute. Stage 4 is when the eGFR is between 29 to 15 ml per minute, and stage 5 is also called as end stage kidney disease or end stage kidney failure, wherein the eGFR is less than 15 ml per minute, or the patient has been put on renal replacement therapy in the form of dialysis. The CKD also can be subclassified based on the albuminuria, which is defined as the loss of albumin in the urine, and herein it is labeled as stage A1 if the albumin loss is less than 30 milligram per gram of creatinine in the urine. Stage A2 when the albumin excretion is between 30 to 300 milligram per gram of creatinine, and A3 when the albumin creatinine ratio is more than 300 milligram per gram of creatinine. Kidneys can stay normal for a long time till a lot of kidney functions is lost. So there may not be any signs or symptoms of kidney disease in the beginning, and kidney disease shows symptoms only when it is too late. So the symptoms can be very subtle. Either the patient may be having to get up for the urination more at night. These must be the uh, first symptoms which the patient may develop and may not recognize. Instead of passing more urine during daytime, the patient starts getting up more frequently at the night to pass urine. He may have swelling over the feet. He may pass blood in the urine. He may have increase in blood pressure because of underlying kidney disease, or there might be easy fatigability, or patient may get tired easily because of decrease in hemoglobin, which is also a feature of chronic kidney disease. So who all are at risk of developing chronic kidney disease? Patients who have family history of diabetes, patients who are elderly, more than 65 years of age, are at risk of developing chronic kidney disease. Patients who have family history of chronic kidney disease again are at increased risk, and patients who have underlying cardiovascular disease are also at increased risk of chronic kidney disease, other than patients who have long-standing diabetes and hypertension. There is a What are the common causes of chronic kidney disease? Yes, diabetes and hypertension are the leading causes of chronic kidney disease, not only in India but all over the world. And another disease which is quite prevalent in most of the tropical countries, some parts of the world, wherein it is known as the CKD of unknown origin, or CKD-U, wherein the patient develops chronic kidney disease because of either the environmental factors, because of impure water they are drinking, or pesticides which are mixed in the soil, and these are responsible for chronic kidney disease. And these patients usually are labeled as CKD of unknown etiology. The other common causes where the chronic kidney disease develops is glomerulonephritis, polycystic kidney disease, which is a hereditary form of kidney disease wherein it may run in families. Then any obstruction to the flow of urine, either because of a stone, because of enlarged prostate in males, or because of neurogenic dysfunction of the bladder, or there is obstruction to the outflow from in the urethra. These also can result in chronic kidney disease. So how can we investigate? What are the investigations which will make us know that the patient has got chronic kidney disease? So usually tests should be done as a routine in patients who are at increased risk, like patients who are diabetic. As I told you, there is a family history of chronic kidney disease. These patients should be screened for chronic kidney disease with a urine examination, wherein we look for any active urinary sediment or protein loss in the urine. If there is a protein loss in the urine, then that urine protein should be quantified with a urine protein creatinine ratio or a urine albumin creatinine ratio. These patients should also undergo blood tests in the form of serum creatinine, which helps us in calculating the EGFR by using different EGFR formulas, and the CKD EPI being the most common. And these patients should also undergo a sonography to look at the kidneys, rule out any structural disease, any obstruction. So the main investigations which are utilized for screening are urine, blood, and sonography. And if there is a detection of any form of kidney disease, in these tests, then specialized tests can be done in the form of complete blood analysis, electrolytes, calcium, phosphorus, and various other tests, specialized tests for the kidney disease. And in some cases, we may do require a kidney biopsy to know the cause of the chronic kidney disease. What what all if once we diagnose? The irony is that once we diagnose, we can only retard the progression of the chronic kidney disease, slow the progression. And what are the things which can retard the progression? In patients who are diabetic, the main thing which can be done is a good control of diabetes. The HbA1c should be usually kept below 7% for a good diabetes control. And if the diabetes is controlled over a long period of time, then the risk of chronic kidney disease and the other microvascular complications decreases. In patients who are having hypertension, the hypertension should be well controlled. Preferably, the BP reading should be 130 by 80, and one should use the nephroprotective antihypertensive drugs in the form of either angiotensin converting enzyme inhibitors or angiotensin receptor blockers, which are useful and controlling the hypertension, decreasing the proteinuria, as well as decreasing the rate of progression of chronic kidney disease. The other things which usually help in reducing the progression of chronic kidney disease is a good lifestyle, weight reduction, which involves weight reduction and avoiding smoking, avoiding alcohol, and various dietary recommendations like restriction of protein intake, restriction of salt intake, restriction of fluid intake, restriction of potassium and phosphorus intake. So these all dietary recommendations, once followed, can reduce the rate of progression of chronic kidney disease and let the patient lead a good and healthy lifestyle. The chronic kidney disease can lead to various complications, like patients can have anemia, which is either because of underlying iron deficiency or because of decreased erythropoietin production by the kidneys. And once we evaluate the patient for the cause of anemia, the anemia has to be corrected with iron supplement if there is a iron deficiency, or the patient has to be given exogenous erythropoietin, which is available in the form of prefilled syringes or injections, which will increase the hemoglobin. The other complication which kidney disease can cause is a mineral metabolism disorder, wherein there is a hyperparathyroidism, and patients usually have hypocalcemia, hyperphosphatemia. There might be vitamin D deficiency because the vitamin D gets activated in the kidney. So there will be vitamin D deficiency. So these patients need to be treated with phosphate binders if the phosphate is not getting controlled with phosphorus reduction in the diet. Then these patients need to be put on phosphate binders, which can be calcium containing phosphate binders or non-calcium containing phosphate binders, along with active form of vitamin D to suppress the parathyroid. These patients also do have a lot of fluid and salt retention because of decreased excretion of salt and water by the kidneys. So these patients also should be either put on a diuretic to increase the water and salt excretion by the kidney, or they should also follow salt restriction and water restriction in their diet. Potassium is excreted exclusively by the kidneys. So in patients with chronic kidney disease, foods which are high in potassium, like non-vegetarian foods, dry fruits, then green leafy vegetables, citrus fruits, all these high potassium containing foods should be prohibited and not allowed to patients who are having chronic kidney disease. So once the patient reaches end-stage kidney failure, or before he reaches end-stage kidney failure, this patient needs to be counseled for renal replacement therapy in the form of dialysis or kidney transplantation. Dialysis is of two types, wherein one is hemodialysis, wherein the blood is filtered from the patient's body, and filtered blood is replaced into the patient's body. This procedure has to be done 3 times a week. Each session lasts for 4 hours, and we need a hemodialysis machine for performing this procedure. This procedure can be done either in the hospital, that which is called as in-center dialysis, or this can also be done at home, which is called as home hemodialysis. The other form of dialysis is peritoneal dialysis, wherein rubber tube or a elastic tube is inserted into the abdomen by a small surgical procedure, and the peritoneal dialysis fluid which is available is put into the abdomen either manually or with the help of a machine. If we do it manually, it is called as chronic ambulatory peritoneal dialysis. If it is done by a machine, it is called as automated peritoneal dialysis. So this peritoneal dialysis is a slow form of dialysis, and this has to be done daily, 7 days a week. And if it is APD, then the patient has to take dialysis overnight. And if it is the CAPD, then the patient needs to change the PD fluid 3 to 4 times a day at the interval of 5 to 6 hours each. Other renal replacement therapy which has been found good in chronic kidney disease is kidney transplantation. This is the best form of renal replacement or kidney replacement therapy which patients of end-stage kidney failure can have. For kidney transplantation, we need to have a donor which can be either a living related donor, a living unrelated donor, which is either a friend or other than the close relative, or we can have a deceased donor, which is usually a patient who has suffered a brain injury and has developed brainstem damage, irreversible brainstem damage. And these deceased donors can donate their organs like heart, lungs, liver, kidney, eyes, and many other organs. So one deceased donor can save 8 lives if the close relatives of the deceased donor agrees to for organ donation. So this donor can help 8 lives at a time. So kidney transplantation is gives the best longevity, the best quality of life for a end-stage kidney failure patient. So what are the things which can do to prevent chronic kidney disease? It is very sad to say that it is very difficult to prevent chronic kidney disease. Once chronic kidney disease develops, we can only slow the progression, or we cannot reverse the disease. So it is a irony that we are unable to prevent chronic kidney disease. Only thing, we can pre-screen patients who are at higher risk, like patients who are diabetic, hypertensive, family history of chronic kidney disease. These patients can be pre-screened and then kept under vigilant follow to prevent, and we should control their diabetes well. They should lead a healthy lifestyle. If they are overweight, then they should reduce their body weight, stop smoking alcohol. So all these things are healthy lifestyle, avoiding smoking, alcohol, and following a balanced diet, a regular exercise program can help the patient prevent from developing chronic kidney disease.